Hey, my name is Caroline Guidry. I'm the student SRNA on the case. I'm looking for the nurse for PACU bed 1 to give report to. Okay, so we have a 32-year-old male with no significant medical or surgical history. He reports no taking of regular medication, but does report smoking 1 pack of cigarettes per month. He presented to the ED with severe pain in his lower right abdominal quadrant. He complained of intense pain that subsided for a little bit, but then returned even more severe. It was accompanied with nausea, vomiting, and a little bit of loss of appetite. The diagnosis was quickly made of a suspected ruptured appendix, and he was emergently taken to the OR for an appendectomy. He was placed under general anesthesia with a 7.5 millimeter cupped endotracheal tube, and it had placement confirmation. Intravenous induction meds were given through bilateral 18-gauge PIVs in the AC that were placed in the ED and a Foley catheter that was placed in pre-op. Patient reported no known drug allergies before, and he was unaware of familial history of anesthetic complications. Preoperatively, the patient received ceftriaxone and metronidazole antibiotics in the ED for the suspected rupture in the appendix, and sodium citrate, citric acid to neutralize his stomach acid, and then midazolam as a sedative while rolled into the OR. Rapid sequent induction was achieved with cricoid pressure and the use of a laryngoscope revealing a grade 1 visualization of the vocal cords for a relatively easy and atraumatic intubation. He is already extubated after multiple attempts, and there will be no need for any continuous vasopressor or sedative drips. It is very important in his respiratory status. It is monitored post-operatively. You would be looking for signs of excessive coughing, wheezing, any reportness of shortness of breath, or tightness feeling in his chest. He does not require any blood pressure parameters, but he will need supplemental oxygen and close monitoring of his oxygen demands. Ideally, his SpO2 would be greater than 95%. Vital signs pre-op were blood pressure 140/65, heart rate 65, temperature was 37 degrees Celsius, and his pulse ox was reading 100% on room air. Most recent vital signs are 150/75 blood pressure, heart rate 70, temp 36.5 degrees Celsius, SpO2 is 98% on 100% FiO2 with a simple face mask. He received about 1 liter of normal saline fluids throughout the case and put out 500 mils in his Foley catheter. Appendectomy went well without any unexpected complications. I, however, had a difficult time during the emergence of the general anesthesia. Approximately 30 minutes before the end of the surgery, as I decreased the concentration of the anesthetic, he began to cough and his oxygen saturation decreased to 60% with sycomoral cyanosis present. Tube placement was confirmed once again, and breath sounds were very severely diminished. Severe bronchospasm was suspected, and I treated it with 12 puffs of albuterol via the ET tube. Isoflurane, the anesthetic, was reinstituted. I gave lidocaine 50 milligrams and sub-Q epinephrine 100 micrograms. SpO2 came back to 94%. I did attempt again a second and a third time with the same refractory bronchospasm, oxygen desat to 60-70. Symptoms resolved when I increased the volatile anesthetic and gave the puffs of albuterol and sub-Q epinephrine. After it was determined that I could not extubate while decreasing the isoflurane because of the bronchospasm, I gave a request for a HELOX tank from respiratory therapy. I placed him on a 70% helium, 30% oxygen mixture using a Jackson-Reese circuit with assisted ventilation. After this, the patient instituted regular respiration pattern, was successfully extubated. I placed him on a face mask with 100%, and like I said, he is satting 98% right now. I drew an ABG after extubating. pH was 7.37, PO2 was 92 millimeters of mercury, PCO2 was 42 millimeters of mercury, hemoglobin 13, hematocrit 40. All electrolytes were in normal limits. Okay, so can you just please let respiratory therapy know that we're on our way? Please tell them that I'm requesting for him to get an immediate nebulized albuterol treatment as soon as we get there. We should be arriving to your unit probably in about 10-15 minutes. Because of the difficult emergence and refractory bronchospasms, you should have respiratory therapy. Just inform them of what happened. Just let them know there might be some residual swelling in the airway, to watch for his respiratory status, oxygen demand, shortness of breath, wheezing, excessive coughing. Critical care specialist should be consulted, monitor for effective refractory bronchospasm and multiple periods of hypoxia, what it had on the lungs and the other organs of the body. Critical care and the general surgery team should also follow the patient's care due to concerns of infection. A ruptured appendix can spread infection throughout and form an abscess within the abdominal cavity, and that could lead to an infection in the bloodstream. So critical care should just be on board for that. General surgery team will be following to monitor post-op surgical infection. That is a common complication of the surgery is post-op surgical infection. Let's see, and then speech language pathologists, I think they should also be consulted before diet is advanced or sips of water are given, because of the bronchospasms, residual swelling in the airway just can lead to difficulty swallowing and risk of aspiration. Okay, so we'll be arriving in PACU about 10 to 15 minutes. Like I said, do you have any questions for me? No? Okay, all right. I'll see you in a little bit. Thanks.